Welcome back to Research Works podcast, another part of our conference series, and we're here at the pre-conference workshop in Melbourne. And I'm very excited because we've finally teed up a time. We've been talking about doing this for a little while. I have here Professor or Dr. Els Ortibus from KU Leuven, but that's your academic title. Do you mind sharing with everyone exactly what it is that you do?
Okay, thank you very much. Yes, we've been looking forward to this for a while
We have
now,
been,
and
haven't
I'm really
we?
very happy. But yes, I'm a pediatric neurologist from background, and I work at the university hospitals in Leuven, where I am a staff member at the Cerebral Palsy Reference Center. And I supervise also the child neurology ward now and then, which is a bit more frightening because I don't do that a lot anymore. And then I'm the head of the Center for Developmental Disabilities, and that is a center where we mainly see children up until the age of 6, where we do diagnostic assessments only. So ambulatory, not residential.
Wow. So you very much are a clinician, you're a researcher, you also supervise a lot of students as well doing their PhD. So you do cover quite a range of areas, don't you?
Yes, I do. And that's very nice. It's good because, of course, because of the population that I care for, take care of. I see a lot of different things going from cerebral palsy to autism, to children who have even DCD or learning problems. So I have to cover a bit of everything. But of course, I do have some main topics that I'm most interested in.
Yes.
But yes, I want to keep track of everything a little bit, like a T person and not an I person. And
I love how you described that. When you first said T person, I thought, that is wonderful. And, you know, your approach in that way is so reflective of how we need to be approaching overall care for the children we work with. Really, we can't be siloed, just one area, the other area, because it's all connected. And I think if we as clinicians can be a bit more T-like, we can also support the journey.
Yes, I think that's really nice that you're saying that, because that is how you have to look at our children, the children that we take care of. And it's also what I teach to the students.
Beautiful.
Because I give classes on comorbidities of cerebral palsy. So the physiotherapists and sit in class and looking at me explaining how children chew their food, etc., and that they have to pay attention to that as well. And have to have, for example, an upright posture in order to be able to eat comfortably.
And I think a marker of a good clinician is one that does understand all these different areas. Otherwise, the experience for the child and the family is one that's very disjointed. So we should all be more T people, I'd say.
Yeah, but we also need I people, of course, because there's a lot of things that we do not understand.
I know. Well, that's a good way to pivot into the I area. Should we talk a little bit about CVI?
Oh, that's a good transition.
Well, when I hear your name, I hear and think about a lot of different areas, but CVI is one of the ones that come to my mind. And I always go, I need to talk to you about CVI because it's an area that I know at university I learned about, and until you become a clinician, you realise the perspective that the children might be having, that you realise how important it is. So can you help us go back to basics? When it comes to CVI, what is it and why is it important for us to know about it?
Okay. So let's talk about the beginning in the 90s, where it was discovered, let's say, where some smart people like Giovanni Cioni did the first publications on it, and then it spread around Europe a little bit. But actually it's about your brain not being able to perceive things as they are, in short. So it's mainly a condition that appears in children who have a brain lesion or a brain altered brain, not necessarily that you see a lesion on the structural scan, because we've been talking about genetic conditions, etc. But also there, over time, we have discovered that a lot of children, even children, for example, with Down syndrome, also suffer from aspects of CVI.
Right.
Because what is very specific about CVI is that it is, just like cerebral palsy, a very heterogeneous condition. If you think that 40% at least of our brain is constantly busy observing and interpreting what we see, then you can understand that when you have a lesion in one part or in another part of the brain, that you can have many different things.
Right, yeah.
It's not as if in an adult where your brain is already formed and you have all the abilities, and then you lose something specifically. Like, for example, you have a motion area in your head, and when you have a little infarction there, you will not be able to see motion, but you can still see all the rest. And that's not what we have in children, where we often have more of a bunch of symptoms, and also a very diffuse picture that is not always so easy to disentangle also from all the other things, all the other comorbidities that they have.
So why is it important for us to understand CVI then for these, and for some of these children, because they are children, they've never experienced, not like an acquired condition where they've never experienced what vision might be like. How do we know it's there?
Yeah, that's also very good, because I have examples of children who were 10 years of age in which we still discovered that they had even just a hemifield loss.
Wow.
They are so used to it and adapted to it that we had never seen it. And all of a sudden they decompensate. So it's very important to detect it early, because it of course has an effect on how you observe the world, how you learn, because we use our vision to learn, which doesn't mean that children who do not have vision cannot learn, but they learn much more slowly. So if we detect it very early on, and let's say from infancy in some of our children, if we can, if we are alert to the potential causes, if they have a brain injury, if they have a genetic condition, you actually should always think about it.
Okay.
And potentially do screening. I know that is a very how would I say that in English? A very difficult term, in the sense that there's lots of discussions about it, whether you can screen, but at least you need to be alert to the potential symptoms. And when children grow older, it's of course much more easy. If you are a 3-year-old in Belgium going to a kindergarten for the first time, and you gradually learn to look in books and describe everything you see, that's sometimes the first moment that you see it, because one of the aspects is that you can, for example, see an apple in 3D, but if you see it in 2D on a little booklet, you don't recognize it anymore. Or if in reality we can discern a tomato from an apple, because we see that the contour are different, the peel is different, and there's that little tiny thing that sticks out, and that's different in an apple and a tomato. And that's what children with CVI, for example, do not perceive. But that's specifically when we're talking about, if I can still use the word, ventral stream. When we're talking about those types of deficiencies in cerebral visual impairment. Because, as I said, you can have a very heterogeneous picture where it's also about visuospatial disabilities, difficulties to navigate in the environment, but also difficulties to navigate in a very busy, crowded picture, where you see the elements, and by naming them one by one, realize that mom is doing the dishes and the children are, in the meantime, stealing a cookie from the drawer, for example.
Yeah, that's a good point. That's a really interesting way of thinking about it, because I suppose if we can detect it earlier and know it is earlier, we can think about the interventions. Otherwise, it is by a process of discovery as they get older where their difficulties might become more apparent, which is quite challenging, I imagine, then, to support them. Is there an element of relearning in a way?
Well, there's not much evidence about intervention.
Okay.
From experience, I know that children can learn. I mean, even when they are older and you teach them strategies to, for example, solve a puzzle. I mean, I won't say that it cures, of course, but they have ways to compensate and circumvent their difficulties. But like, for example, this afternoon, I will be also talking about the games that we developed specifically for visual perceptual training. And there we did prove that it works.
Right.
As long as you work on the specific elements that they are deficient in.
Okay.
Because you have different visual perceptual abilities and difficulties, like object recognition or visuospatial, looking in a cluttered environment.
Okay.
motion also, and if you can work on them more specifically, then there is proof that you can probably move forward faster
A bit more targeted.
than when you, yes, targeted intervention, than when you would do just general training of visual perceptual
because
abilities.
otherwise, like you said, because it's so heterogeneous, you just go CVI.
Yes.
So and the elements you're talking about there, that's part of the assessment, I imagine, then, to understand the components of it. Do you mind just going to the assessment part for us? Because I feel like that's the biggest mystery sometimes of what is part of it. What is...
Well, that's what we do not always agree on, and I think that's why we are writing the EACD-CVI guidelines. Beautiful. Because that's specifically on assessment. And yes, I think the first part is that you send your child off to the ophthalmologist, so that at least you know, does he have a problem with, for example, acuity? And if he has a problem, first correct it, if you can, with glasses.
Are we saying we should do this with every child that is diagnosed, or we
with
look at
every child with a developmental disability? Actually, you should do ophthalmology.
Okay.
It gives you clues to the diagnosis, but it also gives you clues to how a child, his visual function is.
I see. Okay.
And then you go over to your neuropsychological assessment.
Okay.
And it's also important to do a cognitive assessment, a motor assessment, a physiomotor assessment.
Okay.
Because the cognitive assessment, for example, if a child is 6 years old but has a cognitive level of 3 years old, it's no use comparing the test results of the visual perceptual testing to a child that to a child of 6 years old. You have to compare it to his cognitive level. And there's, in the assessment, there's of course different things that you look at: objects, scene recognition, motion perception, coherence perception, which is related to that, local global.
Okay.
And then also visual memory you could have a look at. But of course, a 3-year-old, that's much harder to test visual memory. So depending on the age or the cognitive age of your child, you can pick what you want.
So ideally, these are all things that you do early as possible, pending the assessments and compliance with following the instructions. Sure. Okay. Yep. And so from there, what happens from there? Is there more assessments to come, or is that enough to give a good picture about how the child is functioning?
What is really very important is also put aside to it the everyday vision-related problems that the children have. We do not know all about that, but we do know that there are some connections between their functional problems and the visual functions and visual perceptual functions that we test.
I see.
So for example, from the studies that we have done in unilateral CP now, we know that vision is also related to bimanual motor function, which is important for you.
Yes, absolutely.
So also for that, it is really very important that you do that visual perceptual assessment. And not only visual perceptual, because, for example, stereoacuity, we have found that in our children with unilateral CP, the right-sided, the left-sided ones, that actually only the left-sided, we're talking about the side, left.
I was going to say, I got that one wrong there. The left side,
The left side. They have more problems with stereoacuity than the other ones.
Is that right?
And so it's very important to, of course, discover that, because if you do not have stereoacuity, it could have an effect on how you estimate distances, etc. And then if you have an effect on your bimanual function, that could be a possibility.
Wow, that's very insightful, Els. So for me as a clinician working with children, part of what I should be doing is actually asking the question whether they've had their assessment done, whether their vision has been assessed when I first meet them. How early on, like if I, with early intervention, early screening these days, you do tend to know that a child might have a diagnosis of cerebral palsy, for example. Sometimes it's developmental and we don't necessarily know the cause. Should we be sending them off pretty quickly, or do we? Wow, okay.
Already when they are going out of the NICU. That's from the group of Elisa Fazzi and Daniela Ricci. They're going to talk this afternoon as well. They have early assessment tools for visual dysfunction, and we know that is also, like we call it, a window to the brain.
Sure.
So we know something about brain functioning if we already look at vision.
Mm.
There's not always a one-to-one relation to what visual dysfunctions you are going to have in the future, of course. But you know that when a child is not able to perceive like another child should, then you have to intervene already.
Okay.
So from the moment that the children get out of the NICU, and then every 3 months, I'm just and the usual moments that we assess our preterms, for example, which is 4 months corrected age, and then 9 or 1 year.
That should be
actually you should follow up, because it's not when you did not see it at first that it cannot come up when the child gets older.
I get it.
So we have a lot of our cerebral palsy children who had never seen an ophthalmologist, where all of a sudden we see, oh, there is something with visual field, for example, and visual perceptual standardized assessment you can do from the age of 3.
Okay.
Because we have developed a few tools for assessment of visual perception. And we actually also developed it for children 24 months, but it hasn't been validated yet. We really struggle to find enough children, but it's really very fun to do.
It's really fascinating, because as you say all that, I keep thinking, yes, what are the things we need to prioritize? Because there's no point at that point, not that there's no point, but the efficacy of interventions you might provide for bimanual functioning, exploration skills for play, you actually need to know what their visual functioning might be first. So in terms of the first person referred to, you mentioned was ophthalmology. If people don't have access to an ophthalmologist, are they assessments or things they can do to at least screen for a vision assessment, or we really should be looking for an ophthalmologist for that verification?
I do think you should be looking for an ophthalmologist. That would be sad that there is no access. So yeah, of course you have tools that also a pediatric neurologist like me can use, but you need the expertise of an ophthalmologist to to go through the whole process. You can screen maybe as a pediatric neurologist, but that's it.
And what you said there also made me reflect, we often think about children who are GMS level 4 and 5, CVI will be on our minds, but we need to be careful not to dismiss children of GMS level 1, 2, and 3 as well. Is that what we're saying here too?
Yes, for sure. Wow. Because you can imagine that GMFCS 1, 2, the children with the unilateral cerebral palsy, they only have one-sided lesion, and there was a time in which we thought that CVI would not be a problem in those kids, but that's really not the case. I mean,
do we know prevalence rates at the moment yet, or are we still trying to develop
Well, we always in general say that children with cerebral palsy have at least 50% to CVI, but specifically for our unilateral cerebral palsy, I must admit, I should go back to my own studies. And that's the one thing I didn't look at before I sat here.
No, that's okay. Well, that was my curiosity taking you there. I can look up your papers for sure, knowing that.
But it's certainly true, because there's a lot more of visual perceptual and visual dysfunction in our children with unilateral CP as well. I think about,
it's almost something that you don't think about, because we keep relating it to the lesion, but we're saying that we don't necessarily understand.
And also because they are cognitively often relatively good, so they can compensate. Like the boy that I was talking to you about, the one who we discovered he really had a visual field problem. He's very, very smart, so he didn't, of course, he has never known
He didn't know any
else.
differently, yes.
It's like children who are really ocularly, visually impaired, and he compensates a lot of those things.
I can imagine with increased load at school, increased demands, it would have become more apparent from his learning. So from an intervention perspective, you mentioned before, it's an area that's still requiring a lot of development. What do we know at the moment about interventions?
There are also in the very young ones now pilot studies. For example, Elisa Fazzi in Italy has done a pilot on intervention, and she did prove in that pilot study that certainly visual acuity improved because they work with, you could call it environmental enrichment, but it's specifically enlightening, literally.
Yeah, nice.
The face of the person you are looking at, the objects the child has to look at. And so those basic functions at least already improved. But of course, the children are very young, so we did not know, of course, what effect it has in the long run on also visual perception. Sure. But you can imagine that if your visual acuity improves, that gives you more input. So it's like watering the flower.
Sure.
If you have more input, then you are more able to, of course, process all those visual stimuli. Although sometimes for a thalamus that is damaged, it could be an overload of information if it is damaged. And then, it could all of a sudden stop his filtering. And then we've had cases of children who actually go blind because they're so tired of looking and compensating all the time that all of a sudden they say, I don't see anything anymore.
Wow. And is the only way you can tell that it's thalamus is from neuroimaging? Is that the way that you would know of that involvement?
It's something that you have to consider in every child. But of course, if you see that the thalamus is really damaged visibly on a structural scan, then you should really take it into account.
Yeah. That graded input, visually the graded input. Yeah.
But we were talking about intervention.
Yes, meandered away into thalamus. Yes, that's okay.
And so, actually we are now, Elisa Fazzi is the PI of a big European project, VIPSTAR, in which we will repeat the RCT that she did in about 100 children. So that's coming over the next year.
Brilliant.
So
we'll keep an eye on that one.
For children between 0 and 3 years of age. So that will be very fascinating.
Great.
But then, other than that, there is a lot of information on interventions. One of the things also is that you have to increase awareness. Also increase awareness that CVI is there. And when people pay more attention to it, they will try to install compensations and strategies to improve, and that already improves the abilities of the children. That has been proven in a few studies as well. For example, adapting your environment in the classroom. When it's very cluttered, the children will be very tired and not pay attention anymore, and then you can't learn anything.
Yeah, sure.
So that's the adaptations. And then, of course, you have the targeted interventions. There have been other groups who have developed serious games for cerebral visual impairment. One more for visual cognitive learning. Then there's the ones from Jonathan Waddington in the UK, who's more about visual field training and visual alertness and attention. And then you have our games, iVision, which then specifically treat different visual perceptual abilities.
That's incredible. And I mean, in terms of the awareness and attention to it, a lot of things that a lot of therapists would be very familiar with is the contrasting backgrounds, it's the using the flashlight, it's using high contrast colors like fluorescent yellow and green and orange. Is that still very relevant in the approaches?
That is still very relevant. I mean, we do it because we feel it works. Of course, we don't have any randomized controlled trials on that. and what we see in the living experience is that every child can have a different preference for different combinations. There's children who prefer black and white. There's others who prefer black on yellow background, etc., etc. So and you have to be careful with colors too, because if you have a lane, for example, that is colored in yellow, he might prefer that color, but then he thinks it's a banana. So
I see.
It makes it more difficult to interpret the picture that he's looking at.
That very individual perspective is important, isn't it? When we are putting together strategies. Els, I feel like I've learned so much from you in that masterclass that is CVI. For the people who are listening right now, what would be your main message that you would really want people to walk away with about CVI?
Well,
would you
the
say
main
that would be?
message is that you really have to be aware of it.
Yeah.
In every child who has a developmental disability, you don't also have to overdiagnose, because it could be something else than CVI. For example, autism spectrum disorder, DCD and the bigger ones, but it could also be a combination of things. So
Okay.
it's not always very easy to disentangle everything. But you have to be aware, and you have to think of it from, when the child
From
is
the
born.
beginning, yeah.
And do be aware that interventions and evidence-based interventions are on the rise. So go and look in the literature, and if you want to collaborate, I think that's also one big message, because it's a nearly rare thing, just like cerebral palsy.
Yeah.
So we need to collaborate to make things move forward.
Yeah, and I guess that's the whole theme of this conference, is developing those networks, and networks to develop. We need to solidify our networks already, because there's so much knowledge, isn't there? Well, thank you. Thank you so much for speaking with me today. I absolutely loved it. And I will be definitely in touch again, because there's a lot more development in this area, which is very exciting to see. And I know this will already change my practice. So thank you, Els. Thank you very much. To all of our listeners, I hope you really enjoyed that. That was just fascinating. There's a lot of take-homes there. So do go and look up some of the papers that Els is part of. But for now, I'll talk to you all again very soon. Thanks and bye.